the prevalence goes from 7 to 80%. 80%. That's a lot. And I think this is often there are a lot of factors, but mismanagement, I believe, is important in this disease. And that's why we see lots of problems happening during nutrition, exercise, etc., which leads to this high prevalence of this disease. I will talk about generalities, then I will talk about the main joints that are affected with this disease, the tarsocrural, the femoropatellar, and the metacarpal or metatarsophalangeal joints. This disease was classified as a developmental orthopedic disease, but since recently it is described as a juvenile osteochondral condition characterized by failure of or defect in the osteochondral ossification that can lead to flaps of osteochondral fragments or subchondral bone cyst. The word osteochondritis refers to the inflammation within this joint, and osteochondrosis dissecans, as you know, is a condition where there is a flap or fragment identified. As I said earlier, it's because of the prevalence. It's quite important disease, and with an economic impact and, of course, performance limiting effect. Many stud books don't approve horses with osteochondrosis, and some horses were lost their value because of this disease. Here we can see a schematic cross-section of an articular epiphyseal cartilage complex, and some recent publications based on available evidence show that there is a focal ischemic necrosis of growth cartilage initiated by necrosis of cartilage canal blood vessels. It seems that everything starts with a necrosis in blood vessels. And here we can see on this pictures from this paper through trans-illumination, you can see those cartilage canals. And when defect happened in this canals, it will trigger osteochondral defect. Here on the left side, we can see the normal pathogenesis of articular osteochondrosis, and which leads to a normal appearance of the cartilage here at the end. On the other side, is it possible to have batteries for this laser? Hello? So we can see that at some point there is a failure of blood vessels here to penetrate the ossified cartilage, and which leads to this defect, which can evolve to a subchondral bone cyst or to a fissure in the cartilage and fragmentation. Here we see this closely, and here this is what happens. Here, this appearance of this defect at this level, and it's which would lead to fragmentation, as we see here in this hock joint. Or it can lead to subchondral bone cyst, like we see here in this fetlock joint. This fragment, as you know, might remain in place or might be floating within the joint, or might go and attach to another location. Risk factors, as I just mentioned, there is a vascular problem, a disruption of vascular supply, but there are also other factors here genetics. It has been well documented and shown that genetics plays a role in osteochondrosis, like in humans as well. Nutrition deficit or excess, and this is where a lot of mistakes happen, or mismanagement, deficits in copper, excess in calorie, protein, etc. But also biomechanical forces. Trauma seems to play an important role, like in children or in adolescent. Osteochondrosis exists, and it seems to be more frequent in those children or adolescent going into sport. Exercise also, and conformation and hormones interaction are also reported as risk factors. But it seems that the interaction between those factors is important. Not only nutrition alone. If you give a lot of proteins, you will not necessarily induce, in young animals, you will not induce osteochondrosis. High global prevalence, as I mentioned, and the sites of predilection are mainly the three we see here. And this is that we can see in common bilateral in mainly the fetlock, the hock, with percentage of 50 in the literature, and the stifle 20%. And when reading X-rays from sails, it's important to re-examine the contralateral joints to look for silent or small osteochondrosis fragments, because it's quite common to have bilateral involvement. Also, the fetlock, it has been also reported that it can affect all the four fetlocks. And also in the hock, multiple lesions can also happen. Here we see the location, and you see it's mainly the highest joints, actually. Those probably who have or were close to, the growth is slower than distally. That's maybe an explanation. All the breeds, rare in ponies, young animals before, young horses as young as 6 months, but in warm bloods when they start training around 3-4 years, you can see those clinical signs, which are mainly, as you know, the joint effusion, insidious or acute, and often without lameness. But when you have lameness, it's often non-apparent or mild, except in the stifle area, or when you have flaps, large flaps that can easily induce apparent lameness. Yeah, the age in diagnosis, it helps. It's often young animals, race horses, yearlings, sport horses around 2-4 years. Lameness, I just talked about. Imaging X-rays provide a good diagnosis, and ultrasonography can be helpful, especially in stifle, in other joints as well. Fetlock, this is a very old picture here of more than 20 years here. Stifle, lateral trochlear ridge, and we can see easily the fragment there. Arthroscopy is the gold standards and give more information than what is seen on X-rays or on ultrasound, of course. On radiography, location of ossification failure is actually very specific. We'll see later on joint by joint, and we should always X-ray the other joints when we suspect it, or in young animals undergoing sales. But we know that radiography severity, the real severity of the lesion, and those performing surgery, you know that most all the time, the lesion is bigger in size than on X-rays, on appearance as well, on arthroscopy. With chronicity, we have the tendency to see round fragments. Timing for radiographs, and this is interesting. As I said, as early as 6 months, but osteochondrosis, like in children, like in human, can heal. The fragments can heal in young age. In children, they know it, they have osteochondrosis, they live normally, and then around 20 years of age, or the fragments disappear. In horses as well, we know that. There is an interesting study, I will talk about it in a moment, that has shown that specifically mainly in the stifle, that the flaps will heal and the fragments will heal. This study from Jacquet et al. In 2013. I will talk about this study in details. Of course, we need to distinguish this fragment from traumatic fragment, like here in the carpus distal lateral radius fragments. Those are not osteoarthritis. And of course, the treatment, I'm still in generalities. Should take into consideration the clinical signs, the severity of lesion, age, use, and owner expectation. Conservative treatment often not of great value. I will talk joint by joint later on, but mainly what we can do, rest, reduce the intake of energy or proteins, and intra-articular medication can be helpful in some cases. Oops. Sorry. Surgery is the treatment of choice in most of the cases, and the prognosis will depend on severity of lesion, existing osteoarthritis, and age in general. Well, arthroscopy are recommended as prophylactic removal, prophylactic removals, sorry, is recommended in a lot of cases. And also long-term health of the joints will be maximized with early surgery, or as we see development of osteoarthritis lesion which need specific treatment. Excellent prognosis in general, but I will talk joint by joint. Now the three main joints are the hock, tarsocrural joint, and often here we will have coincidental finding on pre-sales X-rays, and it's more common in warm bloods and standardbred than in thoroughbreds. Also, we can have some silent lesions, more in this joint than in other joints. The most frequent locations by decreasing frequency is the distal intermediate ridge of the tibia, as you know, the distal lateral trochlear ridge, talus, medial malleolus, but the distal medial trochlear ridge lesions here are considered as a variation of normal in the medial side. Oops, a dying laser, or already died maybe. Clinical signs, nothing very different. Effusion, bug, called lameness is uncommon and usually in young animals. And you can see here different type of fragmentation of the distal intermediate ridge, some small, some bigger. And the distal lateral trochlear ridge, often we have small fragments, but they can be large as well, but they still have good prognosis. The medial malleolus, sometimes difficult to diagnose. The effusion seen also with the beginning of the training, and radiography, the dorsolateral plantar medial oblique acquired 2 dorsoplantar can be helpful for the diagnosis. This is an old study from the McElroy team in the beginning of the 90s. It's still a valuable, one of the first important studies at that time about the prevalence of osteochondrosis. And this study was performed on more horses than that, but on 183, they followed those horses there was no effect of size of the distal intermediate ridge of the tibia on horses. However, osteoarthritis lesions decreased the prognosis, which makes sense, and there was less resolution of effusion with lesions of the medial malleolus and the lateral trochlear ridge than those lesions that have been seen in the distal intermediate ridge. 76% of the horses raced again successfully, and there was no effect of performance. Conservative treatment in the hock possible when we have small single lesions without effusion. An old study from Belgium, I think, have shown that there is a better option. This is a better option, this conservative treatment in warm bloods than in racing horses like standard breds. But surgery is indicated wherever there's any lesion with clinical sign. The prognosis, if you see all the literature, is more than 80%, which is excellent. And it has been reported also that effusion in cases of distal intermediate ridge of the tibia osteochondrosis can improve by 50% after the surgery. The stifle. More common in thoroughbreds than others, and age also approximately 60% affected horses have less than 1 year, and often the clinical signs often have more severe damage within the joints, and in older horses we can have incidental lesion as well, without clinical case. We have seen several horses that compete at high level in jumping, for example, with lesions that are there, flaps that are there, and obviously the horse is doing very well with such lesion. Site of predilection, as you know, lateral trochlear ridge by far is the location of predilection, followed by the medial trochlear ridge of the femur, distal end of the patella, and the trochlear groove. Can also be bilateral. Lateral trochlear ridge, like we can see here, can go from the flattening alone until smaller lesion, until more, I can see the bottom right lesion. We can see very extensive lesion. Arthroscopy, it's performed on mainly on the lateral trochlear ridge, rarely the medial, and the synovial effusion also correlated with lesion size. Larger fragments have the tendency to give more clinical signs. A rare situation with yearling and weanling. Conservative treatment here is possible and indicated in horses that are less than 18 months theoretically, based on studies, even though if we have clinical sign. There is McWright has advised that if no fragmentation or if in situ fragment less than 2 centimeters and less than 5 millimeter deep, we can proceed with conservative treatment. But if the fragments are bigger, more than 2 centimeters and more than 5 millimeter deep in the trochlear ridge, surgery is indicated. Prognosis of surgery is excellent. in most of the cases. The fetlock, some debate about osteochondrosis. I will talk about it. So clinical signs, not much different than the others. Swelling, joint swelling, flexion test because of the distension shows that there is pain in this joint, and can be bilateral, but it can be also quadrilateral in such horses. X-rays confirms the lesion. Ultrasonography is very helpful here, and because we can also have clinically silent lesions where ultrasonography can help much here. Location and frequency. The dorsal proximal aspects of mid-sagittal ridge is a common location. The palmar or plantar aspects of P1, it has been often classified as osteochondrosis, but it's controversial. And current belief is more that it's traumatic than osteochondrosis, sorry. And there is a publication here that goes, this Dallin and a collaborator have shown that it's more traumatic than osteochondrosis. Also, the dorsal parasagittal aspect of the third metacarpus or metatarsus is oslocation. Is also another location. But the distal aspects of the sagittal ridge of the cannon bone, we'll see here in red, this flattening, it's not osteochondrosis. So here you can see the proximal sagittal ridge of the cannon bone. The plantar P1 fragment, which is a debate, still talking about it. Distal sagittal ridge, we can see this lucency here, and this is not osteochondrosis classified. Dorsal condylar parasagittal fragment too. Decision making in the fetlock. Conservative treatment is indicated in the sagittal ridge flattening with or without fragment, but also lesions with surgical treatment in lesions with fragmentation and surgical removal of the plantar fragment. There have been recent study that shows that is controversial. This paper in Trotters by James Carmelt and collaborator has shown that there is no difference between removing those fragments and not removing them in terms of performance of such horses. So certainly more studies are needed and a lot of questions are still to be answered. Prognosis of surgery seems excellent, more than 90%. Well, this study was performed in France and published like 10 years ago. The aim was to evaluate spontaneous evolution of radiographic finding of osteochondrosis in field study. And they were taking radiographs at 6 months and then at 18 months in 321 young horses from 3 breeds, standardbred, warm blood, and thoroughbred, and reevaluated at 18 months and classified as disappeared, improved, stable, deteriorated, or new lesions. The results were interesting. In Stifle, 85% of the cases of fragments of the lateral trochlear ridge of the femur have disappeared or improved, like in human. In the hocks, stabilization of half almost of the distal intermediate ridge, fetlock, the dorsal and plantar osteochondral fragments were frequently observed as new radiographic abnormalities, which probably is weighing the balance toward traumatic origin. And conclusion of this study that a definitive radiographic assessment of osteochondrosis stages is more reliable at 1.5 years. And knowing the spontaneous healing capacity of some lesions, especially in the stifle, this is useful in helping to decide the appropriate management. I think this is an interesting contribution, this study, and our knowledge about osteochondrosis management. Take-home messages: if we have falls with normal joints, radiographic checkup at 1 month and a half is advised. If the falls have joint swelling or lameness, concomitant lameness between 1.5 years, a checkup for osteochondrosis is necessary. And adult horses with osteochondral fragments in a joint, and the clinical, depending on the size, etc., clinical assessment and imaging are necessary to decide if the fragment needs to be removed or not. Bilateral frequent lesions are frequent, and we should keep in mind the importance of risk factors to sensitize the owner, trainers, etc., about those risks, and or else some keep creating osteochondrosis in some horses. After 1.5 years, big majority of osteochondral fragments need to be surgically removed, and the prognosis for surgery in the major affected joints is excellent, except in some joints, as we know, like shoulder, which is around 50%. Thank you very much for your attention.
Thank you, Aziz, for this comprehensive overview. As a final speaker of this session, we have again Professor Goodrick with a presentation on the orthopedic surgical complications and management strategies.